Good morning, everyone. Put on my video so you can see me. Good morning, everyone. Thank you so much for joining. We appreciate your being here on a Saturday morning. We will be starting soon. This is 10 o'clock. We'll be starting soon in the next 5 to 7 minutes. We just wait for more people to join and then we'll get started. Thank you again. If you have any questions before we start, you can drop it in the chat box and we'll take your questions. Thank you. Good morning, ma'am. Good morning, Dr. Love. You're welcome. You're muted. You're muted.
Okay, that's good.
Very, very clear. Happy International Women's Day to you.
Thank you. I same to you too.
To everyone on the call as well. So today we are starting right away. So today we are talking. I'm sure more people will join, and if they can't join, the video it's being recorded, so that we are going to share to as many people as possible. So today, basically, we will be talking based on the agenda that we shared. We want to, field is always at the forefront of doing anything that has to do with maternal health. This is a new commitment that we took on board when we started when we got the grant to make sure every facility in Nigeria and in Kenya has access to all that they need to wage the war against maternal mortality. But that's not what we are starting with this morning. This morning we are talking endometriosis, beyond the pain. That's what we are starting with, endometriosis. It's based on my research. When I was doing a lot of research about it, I realized that some studies, even one that was done in Ibadan, research that was done in Ibadan said that it's underdiagnosed in the African woman. So I'll just like you to start, tell us more, what is endometriosis and what causes it?
Okay, endometriosis is a gynecological condition. I'll describe it as an estrogen-dependent inflammatory condition, whereby you see the endometrial cells that ideally should be in the lining of the womb, and you see them in other parts of the body. That's what I'll call endometriosis. It's kind of, an ectopic condition. This thing is supposed ideally to be in the womb or in the, where we menstruate from as women. But in this case, they now appear in other places, thereby mimicking the features, those things that happens when the woman menstruates will now be happening in those places you're seeing those endometrial cells. That is a condition called endometriosis. So it depends on where you see it. It can be in the peritoneum, in the ovary, in the brain, in the chest, in the gastrointestinal system. Wherever it appears, it begins to manifest and behave as such. So that is a condition called endometriosis. As per the cause of endometriosis, there is no particular cause that has been, identified, any particular thing that has been said, this is the cause of endometriosis. However, there are so many theories that has been postulated, as to, in a bit, to explain how come or how endometriosis has come about. Okay, one of the commonest theories of endometriosis of the causes of endometriosis is retrograde menstruation. What is retrograde menstruation? What it means is that, when a woman is menstruating, the period will be coming through the genital tract, the vagina, and out that way. In retrograde, it's just as if there is a backlog, of that. Yes, now going back through the fallopian tubes and spilling into the peritoneal cavity. That is what they call retrograde menstruation. But you will also see that there are people that have not even started having, if you go by that theory, it means that a woman that has not started having period will not have endometriosis. But sometimes there are women, young ladies that have not even started menstruating and they have features of endometriosis. So you see the dilemma in finding the cause of endometriosis. So, but that is one theory. Okay, but it doesn't mean that endometriosis cannot happen without period. No, it does. Of course, we see it in the brain cells. You see it in so many other places in women that does not menstruate yet. So that is one thing about endometriosis. It has so many theories. So there's another theory of endometriosis. One of them is let me call that one embryological theory. It's been found that some cells of this endometrium, there are other parts of our body that have similar cells that originate from the same place that these endometrial cells originate. So what happens is that when those other organs that have similar origin, embryological origin, like the endometriosis, sometimes you see them transform, they undergo metaplastic transformation and begin to behave like the endometrium.
Outside,
even outside, wherever they are. Maybe our skin was originating, our teeth was formed from the ectoderm, endoderm and mesoderm, and origins of the body. And you see that the hairs and the teeth are originating from some place. Sometimes you see hair, the teeth growing on your head because they have similar origin. So that is one of the theories. So it is believed that this one is used to explain endometriosis in the brain, because there are people that bleed into the brain and it's endometriosis. So that is, it's believed that those the thalamic membrane, those things that are similar to endometriosis that are found in the brain, and they begin to behave like endometriotic cells. Another theory is immune theory. You know, the theory of this one is, when you have a dysfunctional immune system, because ideally when some of these cells go in the places they are not supposed to be, the immune system tend to mop up these cells. So when your immune system is dysfunctional, and it fails to mop up some of these endometriotic or wherever the village or wherever the cells are. So these are the few theories about endometriosis. Okay, and as per the cause, so you see that if you see this about retrograde menstruation, you see that if you have any condition that have like blockage of your genital tract, like some women that have infrared hymen, or those that have presence of a transvaginal septum, when there is a blockage to the outflowing of the menstruum, you see that spillage occurs, and then the endometrial cell deposits in these places that it has spilled into and begin to grow there. So these are the few theories of endometriosis. Okay, so, and like I said, but there is no particular cause. There are just theories that have been postulated.
Wouldn't this make diagnosis, or hasn't this made diagnosis how will I say it now, a bit hard or a bit difficult?
Of course it is. It is definitely, but we thank God for technology, and actually that is why we are here, to bring awareness about endometriosis. And in as much as there are some diagnostic dilemma, maybe for infrastructural reasons or financial reasons, but it doesn't mean that it cannot be diagnosed. Of course, it can be diagnosed, even clinically. Some people, if you have worked in a rural place where you don't have all the diagnostic acumen, it doesn't mean that, or diagnostic tools, it doesn't mean that we don't treat and manage endometriosis. Of course we do. It has clinical presentation, what you see, and you begin to think, oh, this lady or this woman has endometriosis. We can diagnose endometriosis on clinical, have laboratory, radiological diagnosis, and even surgical diagnosis. The diagnostic tool, or the most important diagnostic tool of endometriosis, is laparoscopy. Okay, it's like you see endometriosis is endometriosis, and you can even, laparoscopy affords you the opportunity to also take a piece of that endometriotic cell and you take it for histology. Okay, but in a situation where what we want to do is, I want to bring about the awareness of endometriosis and holistic care of endometriosis. So you don't have to wait until you do laparoscopy. You don't leave the woman in pain. Our team says beyond the pain. You don't have to suffer the pain. I don't have money to do laparoscopy. Doesn't mean this woman should be sentenced to everlasting pain. No. The features that we see, I'm going to mention them now, will help us to bring, calm down on the diagnosis and begin to manage. But there are sometimes we diagnose by trial of treatment. There are some conditions you see, they're not very sure of what it is, but let me do this. By the time you give them this medication and the person gets better, oh, that diagnose in retrospect, oh, this could be this. So the point is that we encourage women to go for diagnosis, but most importantly, we do not want our women to be in pain because they do not have the wherewithal to do laparoscopy or other invasive investigation. So we will talk about other things about endometriosis, and I'll come to diagnosis. The diagnostic too is laparoscopy, but beyond laparoscopy, we want to talk about the features of endometriosis and how we get our women out of the pain that they are having.
Before you move on to how we can manage that, manage it better, holistic care and all of that, I just want to mention that we will be having some pharmacists either on the webinar or watching the video after. And in our society, either in Nigeria or Kenya, because we invited our Kenya counterparts as well, sometimes to get to the hospital might not be the first port of call. Maybe because of funds or accessibility. When you are telling us about beyond the pain, holistic care, I just want you to know that there are some pharmacists that might be around, so we can tell them this might be how you can help before you refer them to the gynae. Yes.
Yes.
I just wanted to add that now. So please, man, let us know how can we help them, help ourselves, our sisters, our friends, and all of that. Go ahead, man.
Okay, how we help ourselves and our fellow women who are suffering endometriosis is by this webinar we are doing to bring about the awareness of this condition, and to tell them that they don't have to, suffer the pain. There are ways out. Just like you mentioned, there are pharmaceutical companies, over-the-counter medications that we can even use to manage the pain before we even go to the hospital. So we help ourselves, one, by educating women that this condition is a gynecological condition, but it's not a life sentence. I would say it's not a life sentence. It is something that has come. It is not any of your making. It's not for some maybe diabolic reason or a sin of yours. No, far from that. There are so many myths about this condition, but what we want to do is to bring help to your door by telling you that this is none of your fault. This is none of your making. You can see there is no particular cause that we have even put our hands to as for why you have endometriosis. Endometriosis has come to be. So it's not something we want you to blame yourself for, or to start thinking that there is no solution. Solution is there, and that is what we are bringing to you. So the things that we'll have to tell you also is that you have to understand that nobody deserves to live in pain. Okay, so when this pain comes, or when you are beginning to think that this my menstrual cramps is out of ordinary, okay, it's a time for you to seek help. If you don't have anybody to call and go to help for, you can start from your pharmacist. Of course, we can get some over-the-counter analgesics that we can manage with. And if the pain is not ameliorated, of course, I'm sure your pharmacist or the healthcare professional will direct you aright to the right health center or hospital to go get help for this condition. So there is help out there for you, and we have brought it to make you know that we know about this condition. We know that this pain is something women suffer. We want to bring it to the know that we are aware. It's not just ordinary menstrual pain. It's endometriosis. So speak up, come out, and we'll get help for you.
Thank you so much. I like that you mentioned that it's not a life sentence.
No, it's not.
When I was researching towards this webinar, I realized that the only webinar that I came across that was for women in Africa, I wrote it down, was African Endometriosis Foundation launch and first annual conference. And that was 4 years ago. They've not done any other. So by the time we upload this might be, this will be another tool for people to look for more information about it. So looking at the information, can you break down for us the treatment options? So we have of course, we have the pharmaceutical treatment options, and then there are some lifestyle modifications as well. If you can share some light on that.
Okay, so the treatment options for endometriosis include, of course, we have pharmacological treatment, we have there are surgical treatment and lifestyle modification. Okay, the pharmacological treatments, the non-steroidal anti-inflammatory drugs, we have some hormonal pills, oral medications, injections, and a whole lot of them. If you understand how endometriosis comes about, you now understand how this medicine works. So we try to, like I said earlier, it's an estrogen-dependent inflammatory condition. So you see why anti-inflammatories are important in the management of endometriosis. We also have some hormones that we use, and surgery. Of course, surgery is the best. It's one of the two, not the best, but it's one of the two. Advantage of surgery is that, like laparoscopy, is that you see and treat. It can be also used as diagnostic and therapeutic options for you. Then there are other life modification that we can use. This life modification is being that I've stated that endometriosis is an inflammatory condition, you see that anti-inflammatories also help, and they are not always in medicine form. Okay, they can be in dietary form. Okay, so what are those anti-inflammatory food items or edibles that we can use? I researched and I found out that some like omega-3, is part of the anti-inflammatory that has been used. And I've watched videos. I went on YouTube and I saw many testimonies as to how omega-3 has helped in management of anti-inflammatory endometriosis. And I understood that what are the foods that we can get omega-3 from. Okay, you don't have to fish, even seafoods have been found to it helps because it's anti-inflammatory, so it helps in the management of endometriosis. It reduces the body, so the pain experienced by women that have endometriosis. Other food items that have also found to help with endometriosis are nuts. Okay, like we have chia seeds and anything nuts help in management of endometriosis. So when we encourage people that have endometriosis to take more of nuts, even antioxidant like vitamin E, A, diet rich in vitamin E. So it's been found also that reduction in red meat consumption has also helped put down, the pain experience or the condition endometriosis. So it brings it down reasonably. And I've had testimonies of women that are managing their endometriosis with just this dietary and some of this lifestyle modification. I also read where the use of a gluten-free diet has been very useful in the management of endometriosis. So in fact, I have a patient that came back to me and was telling me how she stopped a whole lot. I was like, how are you going home and all that? But the time I saw that her visit, the frequency of her visit has reduced. Yeah, I was like, well, say, doctor, I'm all, in fact, there were so many things. I don't take this, I don't take that. They say this and all that. I do not this, I do not that. Ask, how do you get it? I get it from here, I get this one from, and honestly, I was so happy for her because, usually before she will come and I don't know, our consultation will be, our mood will be so low and all that because of the pain. And, she's so worried because, this endometriosis, the pain and even the other condition like infertility associated with it, in fact, it's a very difficult situation where you are managing pain, and on top of that, there is also the issue of
therapy in the consulting room as well.
So, but with this life modification that she made, she have the frequency of her visitation dropped. So that even encouraged me the more to say that the food, lifestyle modification or dietary modification also helps in management of, it's one of the treatment options for endometriosis.
Okay, so you mentioned the infertility part. There are several cases of some women who say, oh, they've been diagnosed with endometriosis, but then they've given birth. Then there are some that they've not been able to give birth. Is there a particular predisposing condition that helps some to give birth and some not to, or it just happens?
Anyway, humans and individuals have their own peculiarity, and the endometriosis are in different severity. Do you understand? There are different mild, moderate, severe degrees of endometriosis. So Mrs. A may have a milder disease, while Mrs. C will have a severe form of the disease. Okay, so that is one thing about endometriosis. So the degree of affectation varies from one person to another. Okay, so that is why you may say this person has had a child and the other person might not have had a child. Then depends on who is managing who. Okay, if the right things are done, the right diagnosis, are we doing the right thing? Are we giving the right medications? Are we doing them at the right time? These are the things that may affect results from one patient to another. Okay, but I also believe that the degree of disease, the severity of disease also affects the fertility management of endometriosis.
What about, so talking about as someone who has, I don't have endometriosis, but during delivery or during the process of getting to delivery, they noticed that I had a lot of fibroids, a whole lot of fibroids. So there was something my gynae told me to be using castor oil packs. And I also read that those with endometriosis are supposedly supposed to benefit from this. What do you think about this? Because there's a whole lot of people saying it now on social media.
Yeah, is the anti-inflammatory part of that oil. Like when I mentioned omega-3, fish oil and all that, fish oil, that is the mechanism of action for that. So, and if even fibroid, endometriosis, adenomyosis, they are all estrogen-driven, inflammatory process. So that is why it seems as if same diets or the oil and all that, they seem to be working together for same people, irrespective of the different conditions.
So basically, we are saying that for going beyond the pain and not just living your life around the pain, there needs to be lifestyle modification. There needs to be the pharmacological part needs to be managed by a specialist to ensure that there's a good balance between estrogen, progesterone, and all of that. And then, of course, the pain medication part as well.
Yeah.
What about food? I know you mentioned the omega-3, our normal food. You mentioned you have a patient who has removed a lot of food. Is it justifiable?
Anyway, I've not done a personal research about it. I'm only telling you an encounter and testimony from people that had used it. So the gluten-free diet is one of it. And food is not like...
How will we survive without bread? This gluten-free.
Of course, we do survive without bread. I don't think I've eaten bread in the last 3 months, and I am good.
Wow. Wow.
Yeah. So we can do without it, honestly. That's what I was saying. When you are determined to do something, or when you are desperate, honestly, you will see yourself doing things that ordinarily you didn't, think you could do those things. So, if you have not been through pain, you would not, if we have been in labor, like women that have been, you will see at that point there are things that cause for desperate action, So just like someone that I don't think I've seen anybody that has endometriosis that had issues with dietary modification. I don't think so. Because you are desperate, you want the pain to stop, you want the pain to end. So I don't think removing 1 or 2 things from your diet would be very difficult for some people to do. And it's not like we are removing it entirely. It's just to have more of this in your meals. Of course, we don't need to break a bank to live healthy or to know. That is not our teaching. We just reduce this, have more of this, fruits, vegetable. All of them, they have antioxidant, they have anti-inflammatory, low fiber diets. They are there, and they're even healthy diet. It will put you in better health condition and in better shape, to be honest about it. Our staple diets, we have a lot of carbohydrates in them and all.
Yes.
So it's something really where I advise any woman that can do it to have, this dietary modification. It doesn't just help with the pain, it also help with keeping you healthy in other health-wise issues. So it's really good that we do this dietary modification. Gluten-free diet, low fiber diets. There's some food map diet for those that are managed for inflammatory bowel disease. And I've gotten testimony of the diet also being helpful. Fruits, vegetables. We say the reduction of red meat. I've even heard of the red meat and even the fibroids, that it helps to prevent it and all of that. But like I said, I've not done a personal study on it, but I have encountered people that have given testimonies of how reduction of 1 or 2 of these food items from their menu has helped them in improvement of their symptoms, especially pain.
Especially pain, yes, because that's the most common symptom that is being presented. Thank you so much, man. So I would like to close this segment by saying that from what we've heard now, we know that endometriosis is not a life sentence. It has happened, and you can handle it. You can deal with it. Pharmacological modifications, lifestyle modifications, and as Dr. Lover said, if you have gone through it, or you've seen someone that has gone through it, lifestyle modifications should not be a problem at all for a healthier you. Okay, so moving to the next segment now, because today is all about women, right? It's all about women.
Yes.
My own saying is that you educate a woman, you have empowered a nation. And with this first segment we've done now, I've learned a lot. I'm a pharmacist. I have a friends in the community pharmacy that I will share this with, so that when the patients come, they can tell them more. The first thing that what I'm taking from this that's stuck in my head, it's not a life sentence. It's not a life sentence. They need to tell more people that it's not a life sentence. So moving into maternal mortality, now we are going to the other end of the spectrum now. We've gone from the end of menses, now to the end of, you've done menses, you are pregnant, and you are about to deliver, right? We are in that place. And statistics say that in Nigeria, in Africa, 531 deaths occur per 100,000 live births. And then in Nigeria, bringing into Nigeria, it's 1,047 deaths per 100,000 live births in Nigeria alone. Please, can you speak to that now? How is that happening?
I wish, I don't know how it's happening, but I'm hoping that before we end, we are going to discuss how to
stop it. Okay.
Okay. So maternal mortality, like you said, is when a woman dies, it's like a whole, people see it in the immediate, oh, sorry, she have lost her mother. But if you see what maternal death does, you will do all you can to stop. Because a mother dies, the husband is left to, the children. If you come to the children, all these juvenile delinquencies and everything that's happening in this society, see that contribute some of these things that's happening in our society that are not, very, we are not proud of. So mortality is a disaster. It is in fact, is something that we must do. All hands must be on deck to make sure that no mother dies. In fact, that is why I specialize in gynecology. Even though I was too young then, I didn't even know how big it is until I got into it. I lost my mother when I was 16 years old, and my life never remained the same. And it has never remained up to even at this age. I still say that some things that happened to me, I'll be like, if mommy was around, it wouldn't have happened. And it's the more reason I'm also doing everything I'm doing to stay alive, because I know if anything happens to you, I will be like, these children will suffer. In fact, it's immeasurable what maternal death does. You cannot measure it all. So, but I believe that after we have had this meeting, we'll do everything in our powers. Every one of us, you don't have to be a doctor, you don't have to be a pharmacist, you don't have to be, all of us, is our responsibility. It's not left for just the doctor or the gynecologist, or no, all of us, the pharmacist, every one of us, everything you must bring to the table to end this menace. This is what I am here for. And that is what my life vision is about. And I'm willing to share and do anything to end maternal mortality.
Wow, wonderful, wonderful. I spoke to a pharmacist, I think she's in Ocean State, and she told me something. I met her at Ujo. She told me something. She said they were in a lecture room. I think she's doing a master's, and they were talking about postpartum hemorrhage as one of the causes of leading causes, one of the leading causes of maternal mortality. And they shared a story. So the professor said, so how many people? I think they told them maybe 10 out of every 100 dies. They were like, oh, well, the figure is too high. So he said, the professor asked her that, what figure do you think is okay? She said she didn't think of it. She just said, and maybe 2 in 100. And the professor said, she said, yes. She said, okay, so what if that 2? One is your cousin, one is your mother. She said, God forbid, God forbid. So you have to, okay, so you know now that it should be 0 in 100.
Zero.
You should be completely 0. So
yes.
that brings us to what field is doing, right? I'm quite passionate about what field is doing. We positioned ourselves, and because of our tech, our reach across Nigeria and Kenya, we're able to partner with the Bill Gates Foundation.
Yeah.
Gave us a grant. This is in addition to what we are doing to make sure that the postpartum hemorrhage bundle is available. Yeah. Not just available to the last mile. So if you are in Zamfara, we will bring it there. Of course, yes, we will bring it there to the last mile. Yeah, and I know you know about the bundle because we presented it at Sorbonne. Now we want to talk to those of us that are here, to those that will be watching after as well. Why should they have this bundle in their hospitals? The misoprostol, the eat-stable Carbitocin, the drapes. Why should it be available? What are your thoughts on that?
My thought is that, thank you for pointing out about the postpartum hemorrhage as a leading cause of maternal mortality. And now that we know the cause, it's very easy to manage. And how do we manage it? It's by use of this bundle that we have successfully, made. Okay. Maternal mortality, the commonest cause of this hemorrhage now is uterine ectomy. Okay, uterine ectomy from so many things, maybe during cesarean section, vaginal delivery, during gestation, polyhydramnios, so many things that cause postpartum hemorrhage. But one good thing about it is that if you anticipate this and you are being proactive and apply prophylactic measures, then you can do very well with the management of it. In fact, you don't even allow it to happen. And even when it happens, then we have everything we need to stop. The drape is one of it. The blood loss during childbirth is overly underestimated. They feel it's normal, a woman deliver, there is blood that comes out, but it needs to be quantified. It needs to be measured. It is not every bleeding from delivery that is assumed normal, and that is why our women, we are losing them. It has to be measured. So if you're able to measure your blood loss, then you're able to replace equal volume for volume loss. That is why that drape is very important. And I will say it will have to get it everywhere. Every woman that delivers should have a measurable blood loss, and the loss should be measured properly. And if guys need to replace it, we'll replace it immediately. And not allowing women to go home anemic and before from anemia, infection, everything is setting, because the death must not happen does not always happen in the hospital.
Yes.
It's something that happens in the hospital, but then the end result is seen out there in the community, and you think we, the hospital, we are exonerated. No, it's our responsibility to put them on their feet the way they work to us in the hospital, or even better than they can. Then what about the injection, the Carbitocin that we're talking about? Is one of the medication we use at delivery, cesarean section. In fact, nowadays, some hospitals I know, I've read about, is their first line. Once a cesarean section, yes, is first line for prophylaxis, so not just for when PPH now comes and now start running helter skelter. So these are things we should have available, stocked in our labor rooms, in our theater, everywhere, and it should be handy, very handy. We have our Carbitocin, those ones have, but this Carbitocin has been found to be very effective. We use it first line in cesarean section. That's what we do. First line in cesarean section. Another prophylaxis for normal vaginal delivery or people that are very high risk. So you grade your patient, you know their risk. You are the obstetrician managing, the midwife, you are the nurse, you are in the hospital where these women are. And you know those that are very high risk. And remember, the low risk can also turn to a high risk. So that is why we need to have all of this handy in our hospitals.
Yeah.
Because prevention is better than cure. That is where I am coming from. You don't have to let a woman bleed before you come. If you give this medication, use this drugs prophylactically, it will help us save lives. It's better we save their life, better we stop the bleeders before they come very bad and we have to do the blood transfusion and all of that. That is not what we want. So our own is that we should make sure that every woman, every hospital, every labor room is stocked with this pack so that we will save the life of our women from postpartum hemorrhage.
Thank you so much for saying that, ma. I was an intern. I did my internship at UCH, Ibadan, and sometimes they will take light, which is normal in our clients, right? Sometimes they will take light. We will have to pack the products, especially we have to pack it with pure water so that it remains like that. I never heard of it stable carbetocin while I was practicing. While I was in I never heard of it. So this is my first time. So reading the studies about, this is what we should have when there is no oxytocin or when there is no cold chain. There's something that can be used, to manage postpartum hemorrhage. Then hearing from you now, that's what is supposed to be, you are using as first line. I mean, it's good to hear, and I'm sure a lot of people will watch this, will learn about it, because we've gone for training in some places. They've not heard about stable carbetocin at all.
Okay. Carbetocin is one of the oxytocin agents that is used in management of labor and delivery. Just like you have partly mentioned, oxytocin is one that, the cold chain has to be properly, maintained. Otherwise, you can see, in fact, I've seen when I was in my training, in my junior training, where you will flog a woman with 8 vials of oxytocin, and yet the womb is looking at you like that, because the preservation of the cold chain was not, we had to suffer a bit before we realized it was from preservation or storage. Okay, so that brings us to the beauty of carbetocin. We don't need all of that temperature, light day, the weather hot, cold. No, we are not there. That's the beauty of it. It's something that when you get it, you use it as it is, and you can be sure of the efficacy of it. So unlike where, of course, even though we are improving in power supply, but that is in some area, depending on where you're living. But if you go to these rural areas where there's power outage and all that, you can agree with me that carbetocin is a very good medication to be handy in such places, so that we are sure of the efficacy and ensure that women are not left to bleed unnecessarily. So that's the beauty of the medication, and I recommend it, and actually plead every obstetrician or every health worker out there to make sure you have this in stock, so that we save the life of our women from this dangerous situation of postpartum hemorrhage.
Thank you, ma. We'll definitely be reaching out to you when we are going to train some places. We'll come and take you with us and go to those places to share
I will show you the road to them, because I did posting in a whole lot of these rural places, and I don't mind showing you the way to them.
Yes, the way you said everybody should have the drips. I was at one of the hospitals, I don't want to mention the name, one of the hospitals in Lagos, and I went there. Some people were bleeding because I was a rep then. I was selling some products, so I could be there. I was given access. I had my gloves and all of that. Some people were bleeding, but they had, this Dr. Brown part. They were like, you just put it there, normal bleeding. Then when I saw the drips and I saw that it's calibrated, you can see when it passed 500 mils, you can see the red line, the green line. Just from looking at it, it improves your visual acuity. You can see that this person is losing too much blood. It's becoming fatal. Let me step in at that point in time. Just that alone, and knowing that it's less than 1,500 naira, has made me so passionate that why can't every woman in Nigeria have it? It's less than data nowadays.
Yes, it is. In fact, I was so happy at the cost when I learned about it, because I go and check the price of the Nightingale that we used to deliver. It even costs more than that, and you dispose of it after, and yet you don't even get good measurement of what estimation of the blood loss. So that brings up to having that it's affordable. Even if it is not affordable, some health institution should subsidize it. These are ways of reducing maternal mortality. Okay, so it should be available, and I believe, in fact, for me, it's cost effective.
Yeah.
Because anything to save the life of a woman, I'm not saying anything about price on it, because you can't put any price on the life of any woman. So it's something we should have, and for me, it's affordable and available. And we should stock it up in all our institutions, and for every woman on a delivery bed should have one available.
Definitely. Thank you so much, man. At this point, I would like to get everyone to ask questions now. There are already like 4 questions here. I think Elizabeth Chukwu says that can you use some of the food or dietary plan for endometriosis management, and is laparoscopy safe?
And laparoscopy, okay. Some of the food items I have mentioned: fish oil. They have seafood, anything seafood, fish and its oil. They are very good. They have nuts. There are plenty nuts. Like I said, don't break the bank. The one your money you can reach, you get it. We have this gluten-free diet. All you need to do is to read the nutritional component of whatever you are buying and make sure that it's gluten-free. They are over the counter in some shops and supermarkets. Just read the breakdown of the constituents, and you see the ones that have more of this and less of gluten, and go for it. So those are a few that I can remember now. And also food items that are rich in vitamin A and E and all of that. So it's about reading whatever you're buying. There's always a nutritional description of the content, and you read them and see who the percentage or the grams or the weight, depending on how it's measured, and then you know the ones to go for.
Did you mention the laparoscopy safe?
Laparoscopy is safe. It's very safe. I was thinking you will be asking the cost. The concern I have is about cost. So as for safety, I thank God where we are in our time and generation. We have improved a lot in technology and expertise. So unlike many years back, so it's safe and available now. Okay, it's safe. It's something I advise. If you can, please go for it. Remember, I said it's static, and we do what we call see and treat. We see the endometriosis, we treat it there and there. So you get 2 things from procedure.
Okay.
So I advise you to go for it. It's safe.
I think the next question is for me, is an indication of interest of Mr. Murtala Wakil, saying that he's interested in the postpartum hemorrhage pack. All right, I will reach out to you, our salesperson. You can just drop it in the chat section for us, which region you are, and the person that is there will reach out to you. It's very affordable and available, and we'll deliver it to you free of charge. Do we have any other questions on the call? We have 8 minutes left. Anybody have any questions? You can unmute yourself. Okay, Miss Elizabeth, please asking.
Okay.
I think that question is for you.
Yes. Okay, so the question about endometriosis, first of all, laparoscopy is a access surgery. So it can remove it. Like I said, the endometriosis have different parts. It can be superficial or deep. So what we do at laparoscopy is that we try to remove as many as we can see and reach. Okay, we remove. That is why I advise we go for it. You see and treat. You see, you can't remove what you cannot see. If they are very deep-seated, there are those that are very deep-seated that the surgeon may not even see or may not even have access to. Fine, it may not be removed, but as much as can be removed will be removed. Okay, so that's what I encourage us to and it is when we go, can we even see the extent or the depth of it. So it's not something a surgeon may tell you now, I'm going to remove everything. Of course, you can't remove what you have not seen. So what I know is that we remove as much as we can see without causing many complications to you. That is what we do. Then about open surgery, laparoscopy is not an open surgery. It's a mini accessory, it's a keyhole surgery where a little bit of hole it's made in your abdomen, and then we look with a camera and this. So it's a minimal access, it's cosmetic, and it's very good. You recover faster and get back to work immediately, unlike the open surgery where you are open, a very much bigger incision is made. Okay, so that is that about open and closed surgery. So laparoscopy is minimal access, while open surgery is just the surgery we know common. You open make a larger incision and then you go, and you don't do those ones with camera.
Thank you. That was a good response. We have Fash saying, can attendees unmute? Yes, you can unmute, please.
All right. Good morning, everyone.
Good morning.
Am I audible?
Very audible.
Okay, I'm Dr. Moses Fache. I'm the Medical Director of ProCare Hospital in Abuja. I'm a senior gynecologist, and I would want to thank the organizers and Dr. Love for her presentation. So I just have a few comments, addition, especially in terms of diagnosis, that there is a current shift from laparoscopy to ultrasound. And we see that the main leading bodies like the European Society of Human Reproduction and Embryology have changed their guideline. In 2008, they said laparoscopy is the gold standard. In 2022, this has been adjusted to say ultrasound is the diagnostic gold standard. And that is because of the challenge in accessing laparoscopy, like Dr. Love has said, the cost, the expertise, even at this time, because patients usually are unable to determine who truly have the skills. And it's just like having a good weapon in the hands of those who do not have the capacity to use it well. It can be very dangerous if you are not conversant with laparoscopy. And it's very easy to go into great vessels and kill the patient. So we're shifting the emphasis to ultrasound. There are cardinal features that we see these days on ultrasound, and you see that there are gynecologists leading this drive to say that transvaginal ultrasound is becoming like the gold standard in diagnosis now, not in management. So you can see things like endometrioma, which of course you can see changes in the uterus like adenomyotic changes. These are usually features that you see. You can do what we call sliding sign, which you can, where you can see whether the uterus is freely gliding through the peritoneal surface. These are features that you can see on ultrasound and gives you a first, very significant likelihood that the patient had endometriosis. The aim is, if you're going to do surgery for such kind of patient, we do not encourage diagnostic laparoscopies anymore in the sense of just go so that you can diagnose a condition. So you must be conversant with treatment so that when you go in, you are able to treat not just the superficial endometriosis like the ones we used to just burn and coagulate. You should be able to even attend to the deep endometriosis, the deep-seated endometriosis. So that is the drive. That's just the comment I want to add to what Dr. Love had told us this morning.
Thank you.
Thank you.
Thank you so much, sir, for that insight. Thank you so much. I'm sure my colleagues have heard you and will probably be visiting you so that we can collaborate with your facility, sir.
Thank you very much.
Thank you, sir. Dr. Love, as you mentioned earlier, you can see someone asking about if it is safe. There's so much we don't know about endometriosis. And I believe that with this webinar, when we share it, because sharing it at a stretch, not everybody will listen, but sharing in bits. For instance, the knowledge we just heard now. Can imagine sharing that particular bit with your permission, sir, if you can share it, letting people know that this is the way diagnosis is going to now. So those that are afraid of laparoscopy can go this way. More people will come out instead of just staying at home with the pain. More people will come out to be diagnosed and get the help that they need to get, and not stay at home and say maybe somebody is doing them or something is happening somewhere. I'm particularly glad to hear that such is happening. Thank you so much, sir. Do we have any other contributions or questions? In the presence of no contributions or no questions, Dr. Love, do you have a final word?
Okay, thank you for the opportunity to speak on this topic that has been quite underdiagnosed or unheard in our environment. Okay. So I'm happy that we are bringing the awareness of this endometriosis to the people out there. And again, that there is something out there for you beyond the pain. So I encourage every woman, like I said, I don't like, you don't have to suffer the pain, so you have to speak up, have to avail yourself, come seek for help, the healthcare professionals. You don't have to bear the pain alone. There is help out there. It's only that we may not know. And now we have brought to our know that there is help for endometriosis. There is a solution beyond that pain. So please do make yourself available. You don't have to die in silence. And for those of us health professionals, let's spread the news out there that there are things. Thank God for Dr. Fatia has even enlightened me the more about the way to go currently. So please, let us raise the voice, be the voice for these women that have endometriosis and bring them to the hospital or to healthcare facilities where they can bring help. Thank you so much for having me today. I am so grateful, and I am so glad that, in fact, I've had my celebration and of the International Women's Day, and I feel fulfilled today. Thank you.
Thank you so much, ma'am. Thank you. And a word on the drapes and the
okay, yes. About the drapes, we have our postpartum PPH bundle. So please, we encourage you to save the life of a woman. We know what the death of a mother can cause to the society in the immediate and in the long term. So please, to circumvent this menace of maternal mortality, like we said, we want 0% of maternal mortality, and we can start by prevention of postpartum hemorrhage by using this drape and this medication, carbetocin. This will go a long way reducing morbidity and mortality in our environment. All of you, your different facilities, even one in the management position to make this, please spread the gospel to them. Take it to them. Tell your managers that we have this product. Can we experiment? We don't mind bringing it to you and trying it out and, experimenting on it. And then, you see for yourself what you can. I have used it by myself. I've used it myself, and I encourage others to use it. It's really very helpful in preventing maternal mortality. So my word for you is, please help us and save the life of our women by preventing maternal mortality via postpartum hemorrhage. Thank you.
Thank you so much. I can't thank you enough. Yes, Dr. Fache, we'll reach out to you, and everyone here will reach out to you personally to make the postpartum hemorrhage pack bundle across to you. For if there's any pharmacist on the call, community pharmacy or patent medicine vendors, you can have the drapes as well, because we know that there are midwives in some communities.
Yeah.
that are birthing mothers, right?
Yeah.
They should have the drips as well.
Yes.
It's not a highfalutin something. Is it? For everybody that attended, we'll try and send you a video of how to use the drips. And for everyone that we have that has indicated interest, like Dr. Monichala, Dr. Fasha said, we'll reach out to you, we'll come to you and show you real life how to use it, and you can buy it at the bundle price. The bundle price, which is better than the normal retail price. So we are looking forward to that. We are starting our campaign of every pharmacy a drip this month, just so that even if the woman wants to go and give birth, she can buy it. It's less than 2,000 naira. Have it in a pack and let them use it. All they have to do is drape the bed and monitor the blood flow. So thank you so much. This is where we come to the end of the program 11. Dr. Love told me it must be 1 hour. So 3 minutes. I like to keep my word. I really do like
it. It is so great.
I really like to keep my word.
Thank you so much. And thank you all that attended. I'm so grateful that we made our time for this. God bless you.
Thank you, sir. And again, thank you so much, sir, for that contribution.
Yes.
All right. Thank you, everyone.
Thank you.